We have done CRIF with ILN for right femurs.
So this is a 13-year-old male with a 1-year-old closed middle third distal third junction fracture of both bones of right forearm with implants in situ. Came for implant removal. Just implant removal, sir. Tensile removal.
How many days old?
1-year-old, sir.
What is the age of the child?
This is 13 years, sir. Yes, sir. This is a 45-year-old male with a compound grade 3B bimalleolar fracture dislocation of right ankle with fibular neck fracture and with no DNVD, sir.
Do you call it a diputant fracture dislocation or a mangled extremity?
Mangled extremity, sir.
Mangled extremity.
Yes, sir. It's a compound injury. This is a pronation abduction type of injury, sir. So this is a immediate.
Go back.
There should be a dislocation of the inferior tibial joint. Diastasis, not dislocation. Diastasis of inferior tibial.
Very important. So you said pronation abduction injury.
Yes, sir.
Is a pronation abduction or pronation external rotation?
This is pronation abduction, sir.
Huh?
Pronation abduction.
Abduction. Which is the better term? Pronation abduction is better term or pronation external rotation is better term? It is high velocity injury, no?
Yes, sir.
What cause of the high velocity? RTA.
Yes, sir. Skid and fall from bike and bike directly fall on the ankle, sir.
No, sir. It is.
He was dragged on the road.
Yes, sir.
He is only driving the vehicle.
Yes, sir.
Mediastem is intact or
There is a stripping of a variation, sir. Stripped off, sir. Immediately we have done reduction in the casualty, sir. After a thorough wound wash. This is a return. We have done ORF with plating for lateral malleolae and two.
debridement did you do in casual?
This wound wash, sir. We are give.
Alone will not be adequate. The raw surface of the fracture medial malleolus
Sir.
fragment has been dragged
Sir.
over the road. All the sand particles, dust particles will be working in the medullary bone, the trabecular pad.
Sir.
Just by simply giving wash will not be adequate, and you are reduced it. Again, the contamination will be staying with the bone itself. You must take a curate or a mosquito artery forceps, try to scrape off the entire raw surface of the medial malleolus, both the avulsive fragment as well as the main tibia,
Okay, sir.
and do initial debridement. All the necrotic material can be excised in the casualty itself with a 11 number blade. Necrotic skin will not be painful. By the time you perform surgery, it will be already more than 12 hours old.
Sir.
What was the gap between the initial injury and the surgery?
About more than 24 hours, sir.
24 hours.
Yes, sir.
Too long a period.
Yes, sir.
Okay. Did you excise any necrotic tissue around the surrounding skin massif?
Yes, sir. We have done. Yes, sir. We have removed the necrotism tissue.
You must excise it.
Yes, sir.
Thorough wash
Sir.
with plenty of normal saline. Initially with tap water or the water what we drink in the bottles, that is relatively non-contaminated. Finally normal saline wash and then hydrogen peroxide. Okay. So that bone has to be scraped here. All the margins of the skin to be excised till it bleeds. Okay, that is a reasonably adequate debridement in the casualty.
Okay, sir.
Fracture also there in your case.
Sir?
You said fibular neck fracture with
Yes, sir. Yes, sir.
So what is the difference between diputant fracture dislocation and Masonry's fracture?
Is there any malleolar, posterior malleolus?
No,
Doesn't
sir.
appear to be okay.
Doesn't appear.
What is this fracture?
Yes, sir.
Proximal fibula. First X-ray.
Fibular neck.
What is that fracture called?
What is the difference between Masonry fracture
Sir.
and a diputant fracture dislocation? What is the difference? Yes or no?
No, sir. No.
Yes, something. Masonry fracture, there is fibular neck fracture with bimalleolar fracture with partial diastasis of the It can be either in the shaft or just near the neck. It is a rotational violence. That is why it will be always a spiral fracture. It's not a transverse fracture. Transverse fractures are due to direct violence.
Yes, sir.
Whereas spiral fractures, the
Rotational
rotational
injuries.
force has been transmitted right up to here. Sometimes there may be only soft tissue injury around the ankle without any obvious bony injury on X-ray. But sometimes you miss the masonry fracture if you don't take an X-ray which includes the knee joint. So it's always imperative to take an X-ray of the whole leg in any ankle injury,
Okay, sir.
including the knee joint, so that you don't miss the masonry fracture.
Okay, sir.
So Brisson distal, there is a partial diastasis of the syndis muscles. In repeated fracture dislocation, there is complete diastasis of the syndis muscle.
Okay, sir.
And the mechanism of injury is pronation, external rotation injury. What is trimalleolar fracture?
If it is posterior malleolus is also involved, it is trimalleolus.
What is trimalleolar fracture? Medial malleus, lateral malleus,
Posterior malleolus.
What is the mechanism of injury? What is the mechanism of injury? Supination, external rotation injury.
Most common stuff.
Okay. Post up.
Yeah. Okay, sir.
Is there any skin loss?
Sir?
Is there any skin loss?
No, we have done debridement, sir, at the before. There is no skin loss, sir.
No skin loss.
Yes, sir.
How is it possible? It appears to be a dragged injury.
Yes, sir.
There must have been skin loss looking at the initial wound. Okay. Could you approximate without tension,
Yes, sir.
or you have left it open?
With we have done suturing, sir.
Okay.
Just a sutures.
So injury is more on the medial side or lateral side? Or the posterior side?
There is more on the medial side, sir. Medial side. Yes, sir.
Where is the sutured wound?
Sir.
Picture.
I didn't. The picture was not operated, sir.
Not taken.
Yes.
Or purposefully you didn't keep it.
No, sir. Not
So
taken.
that KJ Reddy will not comment on.
Just stage sutures we have done, sir. Stage sutures we have done. Yes, approximate.
Okay, if there is skin loss,
Sir.
if you are not able to approximate, what will you do? Bone is exposed.
Yes, sir. We'll leave it for a secondary suturing.
Devoid of periosteum. There is no skin cover. It appears as if the injury is a lacerated one due to dislocation of the ankle. As the wound appears here,
Sir.
it appears due to dislocation. The skin gets ruptured transversely, usually at the level of the fracture. It is just above the fracture. Not the, what do you think by looking at this? When you are able to approximate the skin margins with loose sutures, it appears that this laceration is due to a dislocation.
Yes, sir. Yes, sir.
It need not be a dragged injury like this on the body. Okay. If the bone is exposed, what would be the management? You are not able to close the
Yes, sir.
wound. Bone is exposed. There is no periosteal covering. Even if periosteal covering is there, how to address that scenario?
You can go for a secondary suturing, sir.
Secondary source. What secondary source?
I mean,
Must mention what is the secondary source.
first we will leave it without suturing. After 48 hours, we will do the suturing, sir.
Do?
We will do the suturing.
Suturing.
Yes, sir.
What is that called? You are not able to approximate the skin margin.
Sir.
And after 48 hours, how are you going to achieve that? If you have no idea, you please tell that
Yes, sir.
I don't know.
Sir.
Just simply keeping quiet is not good.
Don't know, sir.
Can anybody answer? Huh? What graph? You have to specifically mention what graph. Flap, not graph. Primary or delayed?
Delayed.
Delayed. Why delay?
And is it contaminated?
When you do thorough debridement, the purpose of the thorough debridement is to decontaminate the wound and make it as sterile as a surgical wound. If you delay it, already the infection, however thoroughly you debride it, is going to have some degree of infection. You cannot remove all the infected material 100%.
So,
You have to give a flap cover, put an X-fix, give a good flap cover so that the vascular flap is going to revascularize the exposed bone. Then subsequently, after 3 weeks or so, when the flap, 3 weeks is the time taken for the maturation of the flap. You can wait for another 3 weeks and then address the fracture. Or just like this, because the lateral part of the ankle is not injured, you do the same thing. And then just like this, what we have done. The flap cover is the best in the first 6 hours itself, so that the chances of infection are greatly minimized.
this is the 37-year-old male, sir, with a closed middle third distal third shaft fracture of left tibia, with undisplaced posterior malleolus fracture and proximal third shaft fracture of fibula with node in VD. We have done closed reduction internal fixation with ILN and CC screw for posterior malleolus, sir. While we are trying to insert the ILN, the posterior malleolus got displaced. So we
Go back to the front X-ray. Where is the posterior malleolus? Zoom in. Is it there? Must be there.
It's undisplaced, sir. It's undisplaced.
Is it there or not? Let's see here. Zoom in. Is there any cortical break?
yes, sir.
Lateral.
Here it is.
Where is it? Is it the fibular fracture or a posterior malleolus?
Posterior malleolus.
Or the same fracture line is extending into the joint. It must have been the fracture line extending into the joint from here. Don't think it is a definitely can see a lucent line. This is appears to be intact.
Yes, sir.
This appears to be the extension of that fracture line. Looks like that. Not a posterior malleolus.
Operatively, you have reported first malleolus.
Yes, sir. Yes, sir.
How?
While we are trying to insert the nail, malleolus got displaced.
That means
Sir.
it is the fracture that is extending. If it got displaced, if it is posterior malleolus, the nail thrust will not get transmitted to the posterior malleolus. That itself is an indication that it is the fracture line extending from the main fracture to the ankle. When you are passing the nail, this fragment must have been pushed. If the posterior malleolus is here, when you push the nail down, it goes directly here. It will not go anywhere near to the posterior malleolus. Very obvious by looking at the initial X-ray itself. My opinion is that this fracture line is extending into the joint. You can clearly see it is not involving the malleolus. Malleolus is only up to here. And that is another proof. When it got displaced, that means it is not malleolus, it is the
part of
same
the.
fracture
Yes.
Suppose you have got that type of presentation. Hello.
Sir, sir, I'm
You
listening.
have taken the CM image. You have got a CM.
It will be
Yes,
done
sir.
under CM only.
One CM only. That is then that.
Yes.
You have to have the image.
Post-op, post-op.
Present the image.
Yes, sir.
Post-op. Zoom now.
Declare.
See, malleolus is only up to here. This is not part of the malleolus. Understood the
Yes, sir.
morphology?
Yes, sir.
It is not malleolus. Okay. What is your impression?
So here, if you see the reduction, there is no extension of the primary fracture till the malleolus.
It is superimposed here. Nail is superimposed.
There is no fracture line communication as such
It must be there.
from the distal third.
See here. There appears to be a existence line. Okay, whatever it is. Now it got displaced.
Yes, sir.
It's a ream nail and ream
The
nail.
articular congruity is
Sir.
maintained.
Raymond nail, sir.
Maintain
It's a closed injury.
posterior cortex running.
Closed only, sir. Raymond nail.
Upper, not full length.
Full length, sir.
Not in the ream nail is in the upper end.
Okay, next.
That's
It
it,
will be
sir.
iatrogenic.
Posterior malleolus, sir.
No, that line is visible even before the reduction. Okay, go.
That's it, sir.
Go ahead.
So, total weight bearing allowed or not allowed? When do you allow that? Total weight bearing after treatment protocol.
After 6 weeks, sir.
After 6
6
weeks.
weeks.
After 6 weeks is over total weight bearing.
I mean, not total weight bearing, partial weight bearing.
When do you advise for total weight bearing? Question is here. When do you advise for total weight bearing? Huh? You should have a clinical and radiological solid bony veneer. Then you should be careful. Otherwise, you'll land up in trouble. Why you should land up in trouble? Because distal third.
Okay, next.
48 years female with closed distal third fracture of left femur, sir. It is undisplaced fracture, sir. And we have done open reduction interfixation with plating for left femur, sir.
A 37-year female with 2 years 3 months post-op case of distal third both bone fracture of the right leg with implant in situ. So she complains of pain at the lower end of the tibia, so she wants to get it removed. So implant removal was done, sir.
Fracture is consolidated well.
Yes, sir.
X-ray is very poor quality.
30-year male with 15 days old closed middle third and lateral 1/3 junction fracture of left clavicle. We have done open reduction, internal fixation with plating for the left clavicle and also bone grafting. Bone grafting was done because of there is a gap of around 3 mm is present over the posterior aspect of the clavicle, sir.
A 3 mm is indicative of bone grafting.
It is suggested to more than 2 mm is suggested to,
More so there is comminution.
sir.
And over and above that there is a delay.
Sir.
More than 2 weeks.
40 years male with closed distal third shaft fracture of left ulna, sir. It's night shift fracture, but mode of injury is fall from bike, sir. We have done open reduction internal fixation with plating for left ulna, sir.
Next.
What type of bearing? Sherman's or DCB?
DCB, sir.
Shermans are not seen, not available.
25 years female with 6 years post-op.
Different, 1/3 tubular is different. Probably you might not have seen the Shermans.
25 years female with 6 years post-op case of middle third shaft fracture of left femur, sir, with implant in situ. And we have done implant removal, sir. 17 years male with 1 month old closed middle third shaft fracture of left humerus, sir. It is a delayed union, sir. We had seen the callus at the fracture site. Attempted callus is present, sir.
1 month old.
1 month old, sir.
Delayed union.
I mean,
Call it as delayed union.
attempted union.
Is already showing reasonably good amounts of callus in 4 weeks. Even with just a arm sling with a shoulder immobilizer, this fracture would go into almost anatomical position and in spite of the gap, it is showing callus, both posterior as well as anterior. With a good quality, you might see. Maybe it may require a brace for another 3 to 4 weeks. It is definitely going to be. What was done for the last 1 month?
He went to native treatment, sir. Native treatment, yes.
It would have definitely united had you treated conservatively. Surgery is unnecessary in this case. Okay.
We have done open reduction internal fixation with plating for left humerus, sir, with bone graftings.
Middle plating.
Yes,
4 plus 4. No bone grafting.
with bone graftings.
With bone grafting.
We have done the callus around the fracture, sir.
Bone graft you are taking.
We used a callus. Iliac crest as used, sir. Yes. Ipsilateral.
It's an adolescent with good bone vascularity compared to a skeletally matured individual. Of course, he is nearing skeletal maturity, and more so, the biology is good here. Biology is very good. So there is no need for bone grafting in such cases because already callus is there. Just stabilization alone will be adequate in this. Bone grafting is unnecessary.
DCB plate. You use a DCB.
You are putting some more morbidity at the iliac crest. Where did you take the graft?
Graft.
From iliac crest, sir.
Iliac crest only. Where? Did you chopped off the crest?
Yes, sir.
Huh?
Yes, sir.
When does it? When does the ossification completes in the iliac crest?
Don't know, sir.
25 years, sir.
25. Maybe around 21, 22. Part of it might have been cartilaginous. It's 17, still the cartilage will be there. So that is not an ideal site. Must take the outer table just below the epiphyseal plate. Only outer table.
What is Reser sign? Resers. R-I-S-S-E-R. Chandrakant. Sai Pradeep Reddy. Reser sign, it indicates one of the indicator of skeletal maturity. The iliac apophysis fuses with the iliac crest at the age of 24 years. That is called Reser sign. That is also one of the indicator of skeletal maturity. What is peak height velocity? Peak height velocity is a better indicator than your Reser sign. Reser sign, chronological, minority age. They are different. So peak height velocity is more important than your Reser sign to indicate your skeletal maturity. Yes, go ahead, sir.
75-year female with closed distal and humerus fracture of the right elbow, sir.
Fresh fracture.
No, sir. She said she fell down 10 days back, but also she has a previous history of fall around 10 years back, sir. Even her range of movements were not complete.
Before the fall.
Yes, sir.
It doesn't look like a, this
Fresh
fracture
fracture.
might be fresh, but this is a malunited distal humeral fracture.
Yes, sir.
See, so much of gross
Degenerative
irregularity.
arthritis and also osteophytes are present.
Joint congruity is not very good.
Sir.
Okay. Is it supracondylar or intercondylar
Intercondylar
extension?
extension.
Extension is
Yes,
there?
sir. Yes, sir. Undi.
Okay.
There is an intercondylar extension with Reisenbohr and Radin classification type 3 with rotational deformity, sir.
Okay.
We opened in the posterior approach and secured the ulnar nerve, and the triceps were cut and reflected, and we stabilized the bony condyles, medial and lateral condyles, and fixed it to the distal end of humerus with K wires. And also, after achieving the reduction, we passed a 4 mm CC screw to stabilize the fracture, and then we sutured it back, sir. These are
Only
this-
K wires.
If we do olecranon osteotomy, it is already the range of movements is not complete, and we can't assure her to regain her full range of movements if we do any plating, and also it appears to be porotic. Plate
Maybe
fixation
a
won't provide.
recon plate contoured to the shape
Sir,
probably would have given additional stability. Recon,
sir,
not the conventional pre-contoured plates.
sir.
Okay. Here you have to immobilize it for 6 weeks
Sir.
with the K wires on.
Postoperatively, we applied slab for
Okay.
75. Hmm.
Next.
34-year male with closed distal and humerus fracture of the right elbow, sir. And there is intercondylar extension on Reisenbohr and Radin classification type 3 with rotational deformity. These are the CT images, and you can see the intercondylar extension over here. We have done open reduction, internal fixation with plating for right humerus, one on the medial side and another on the posterior lateral aspect of the humerus. 99. And also we have done olecranon osteotomy, and for which we have done tension band wiring, and immediately after the surgery we have started mobilizing the patient. C2, sir. Comminution complete గా ఏం లేదు. వెజ్ ఉంది, సో ప్రాపర్ కమ్యూనికేషన్ అంటే C3 ఉంటుంది. దిస్ ఇస్ నాట్ ప్రాపర్, it is C2.
Metaphyseal comminution, articular comminution.
Sir. పెట్టాను.
The trochlear notch appears to be intact here. That is one good aspect of this fracture.
Sir.
Trochlear notch appears, it is the
Intact.
capitellar part of the lateral condyle that is articulating with the radial head
Radial head.
mostly. Okay.
Intraarticular fracture, 1990, construct is better. Intraarticular, extraarticular fracture or partial intraarticular fracture. Parallel plating is better. That is hypomnesia.
74 years, male with intertrochanteric fracture of left femur, sir. It's around reverse oblique type, sir. We have done closure reduction, internal fixation with PFN, sir. Long PFN, sir. These are the intra pics, CM pics. Yes, sir.
Good morning, sir. These are the cases done under Unit 2, sir. 46-year male, post-op case of bimalleolar fracture of left ankle with implant in situ. We have done implant removal, sir. Yes, sir. Changes are there.
Osteophytes are there, posterior narrowing of the posterior joint space, marginal osteophyte case. There must have been articular incongruity leading to postcondylar osteophyte.
70-year male, sir, intertrochanteric fracture of left femur. We have done close reduction internal fixation with long PFN for left femur. Two cases.
Good morning, sir. Today I am going to discuss whether anterior malreduction is associated with lax screw cutout after internal fixation of intertrochanteric fractures. So the study is to know whether the anterior malreduction is a risk factor for a screw cutout, sir. So first, let us see what is anterior malreduction. So anterior malreduction is in lateral oblique views after fixation. The distal fragment is anterior to that of the proximal neck fragment. It is considered anterior malreduction. If it is in continuation, it is anatomic reduction. If it is posterior, it is posterior malreduction. So our study is to see whether this anterior malreduction is a risk factor for a screw cutout or not. What they have done is they have taken all the patients of anterior malreduction as one set, and the remaining these patients with anatomic and posterior malreduction as one set, sir. Coming to journal, this is a retrospective observational study published in Clinical Orthopedic Related Research in September 2023. The main work is done in Tokyo University Hospital, Tokyo, Japan, and 5 other associated facilities during the study period of July 2011 to December 2017, sir. So the main purpose of the study is following internal fixation of IT fractures to know whether malreduction in lateral view, especially anterior malreduction, and post-op sliding of the screw are associated with screw cutout. That is to know whether these are risk factors for screw cutout or not. That is the main aim of the study. Coming to introduction, complications like lax screw cutout leads to failure of fixation, which causes walking impairment, and that leads to increased social care of the patient and increasing social burden. So even though this is a rare complication, screw cutout, but owing to increased burden of the IT fractures that was increasing annually, tackling these complications forms an important area for concern. So preventing screw cutout is of a great interest to both surgeons and health policy makers. So first, let us understand what actually is screw cutout means. It is the extrusion of the lax screw through the femoral head protruding into the hip joint, usually demanding replacement surgeries. So the well-known associated risk factors are the greater tip apex distance. Tip apex distance is the distance from the tip of the screw to the femoral head in both AP and lateral views. There is TADs in both sum of both AP and lateral views. So if it is greater, the greater TAD is a well-known risk factor for the screw cutout. And other risk factors are poor bone quality, improper lax screw position, fracture pattern. Sir?
What is normal TAD? What is abnormal? Previous slide.
Sir. Normal TAD is some of the
Quantity.
25 mm, usually 25 mm, sir. Yes.
How do people know that?
In further studies, I will explain that, sir.
Here only you have to define
Sir.
what is TAD. When you are defining TAD,
Sir.
you have to put what is normal TAD.
In this study, they have taken different ones. 20 mm as the.
What is conventionally followed, what they have followed, then you have to compare between this
Yes, I will explain that.
conventional what the textbooks say.
Yes, I will. In further slides.
Ideal.
What is the full form of TAD?
Tip apex distance.
Tip apex distance.
Okay, sir. And other risk factors are poor bone quality, improper lax screw position, fracture pattern, and the old age. So these are the known risk factors, but risk factors, risk nature associated with anterior malreduction and post-op sliding are not known. So that is the aim today to understand their risk nature. Coming to materials and methods, this is a retrospective nested case control study. Inclusion criteria is patients greater than 65 years who had internal fixation for IT fractures, whether it might be cephalomedular nailing or sliding hip screw, during the study period of July 2011 to 2017. And the exclusion criteria is patients with subtrochanteric fractures and patients with pathological fractures associated with malignancy are excluded. So,
CMN, cephalomedullary nailing, or SHS, sliding hip screw. What is other name for SHS?
DHS.
So both are matching.
So
One is extramedullary, one is intramedullary.
yes, sir.
Both are matching.
No. What the study is internal fixation, so whether it might be. Yes, sir. So following this inclusion and exclusion criteria, total they have selected 2327 patients, 2327 patients. Out of these patients, they have seen in among screw cutout in 36 patients, and they have considered this as a case group. And the remaining 2291 patients are taken as candidates for controls, not as controls. So once they have taken as candidates for controls, they have defined two definitions. That is one risk onset duration in cases group, that is the duration between surgery and the cutout, and observational duration in controls, that is the duration between surgery and the last radio gap. By matching these two durations, they have defined risk set sampling, followed by age and gender matching and random selection. Finally they have taken 135 members of in control groups. So totally we have got 36 cases and 135 control group out of 2327 patients. Once they have taken cases and controls, they have started taking information, the data from the documents that are available in the respective hospitals, like age, sex, preoperative condition, lifestyle, yes, everything. So the summary of the table goes like this. In cases, the mean age is about 85 years, and controls it is 85 years again.
Mean age is 85.
85 is the mean age.
That is Japan.
Yes, sir.
They live around
Yes,
up to 100 years.
Yes, sir.
Our mean age will be around maybe 60.
The female ratio in cases is 89%, and controls is 91%. That is mostly females are taken in this study. And in cases, out of 36, 35 patients are shown to have the cephalomedullary nailing. That is, only one patient of SHS is shown to have screw cutout. This is because usually SHS is done in patients with stable fractures. Usually SHS is done in stable fractures, sir. So that might be the reason why patients of cephalomedullary nailing is having more ratio of screw cutout possibility. So out of these 36 patients, 3 opted for no further intervention, 3 underwent secondary fixation, and 30 patients underwent conversion to arthroplasty. This shows the demand for secondary arthroplasty following lax screw cutout. Yes, sir. Yes, sir. Yes, sir. Yes, sir. 17. It is seen that in cases about 33% of the patients shown to have TAD greater than or equal to 20 mm, and about 42% is shown to have anterior malrotation, and 52% have patients having post-op sliding. That is, the limit is taken as greater than or equal to 6 mm within the initial 2 weeks of surgery. So these percentages shows the associated risk nature of these factors with the lax screw cutout, so demanding the need for exploring these as risk factors. And also it is seen that there is no signs of infection in all case group patients. So out of 36, there is no incidence of any case infection. So removing the infection as a confounding factor in this study. So coming to statistical analysis, the association between the sagittal reduction, that is anterior malrotation, and the post-op sliding with cutout was estimated using conditional logistic regression analysis adjusted for age and sex. And the software they have used is the Stata version 16.0. Coming to results, in patients with anatomic reduction or posterior malreduction and with TAD less than 20 mm, they have taken odds ratio as 1 as base. Patients with anterior malreduction with lesser TAD is shown to have odds ratio is 4.2. We know that odds ratio greater than 1 is a positive association. So it shows anterior malreduction is associated with the lax screw cutout. Similarly, anatomic reduction and posterior malreduction with a greater TAD is also shown to have positive association with the lax screw cutout. And patients with both anterior malreduction and TAD greater than 20 is shown to have about more than 20, sir. More than 20 is shown to have greater association about 10, that is very strong association. So this information shows that anterior malreduction and TAD are greater than 20 are the risk factors, independent risk factors, but the interaction term, that is the association between these two is 0.6, which means there is no association between these two variables. And similarly, the post-op sliding, that is greater than or equal to 6 mm within the initial 2 weeks of surgery is 11, again a positive association. So this establishes TAD greater than 20, anterior malreduction and posterior sliding of greater than 6 mm within 2 weeks as independent risk factors for screw cutter. So that is what our aim is, and we have done. Yes, sir, 6 mm within the initial 2 weeks of surgery as sliding, sir, post-op sliding. It might be anything, sir. Yes, sir. The denomination about that. So we have seen, we have concluded that anterior malreduction is a risk factor, but let us see how it causes anterior lax screw cutout. So how does a anterior malreduction causes lax screw cutout? Let us understand this. In posterior malreduction, in anterior in anatomic reduction, we can see the distal fragment is in continuation with that of the neck fragment in both these. So whenever patient tries to weight bear, the forces are transmitted from the diaphysis into the neck and followed by hip. So there is a continuation, but in anterior malreduction, there is no continuation between these two. So whenever he tries to weight bear, the neck fragment goes into the medullary canal, slips into the medullary canal, and forces are not transmitted from diaphysis into the neck. And these forces are directly falls onto the lax screw, leading to lax screw cutout.
Is there any positive effect, negative effect, neutral effect? No.
They didn't mention anything, sir. Yes, sir. Yes, sir.
What do you mean by neutral effect? Cortex to cortex.
Yes, sir. And also insufficient bone contact between these two fragments leads to sliding of the screw, which in turn causes lax screw cutout. So both by direct and indirect effect, anterior malreduction is responsible for lax screw cutout. So coming to the positives of this study, previous studies showed indirect association between anterior malreduction and the screw cutout, but this study has established direct association between these two. And as the study included more than 2,000 patients and also met statistical requirements, the results are considered reliable. Coming to limitations, these results cannot be applied to SHS because of potential selection bias. We have seen only one patient of SHS shown to have lax screw cutout, so we cannot apply just to SHS. Also, this study is done in homogeneous group of people, that is in Japanese. Need for a heterogeneous spread of this study is required, and mixed assessment methods of reduction quality were not used, and some data was missing as this was a retrospective study, and the influence of other confounding factors like surgeon's experience level, fracture type, implant manufacturer were not addressed in the study. They have taken only just two confounding factors, that is age and sex, and they have matched it. Other confounding factors they were not addressed, sir. So coming to take home message, well performed surgical treatment of an intertrochanteric fracture requires avoiding anterior malreduction and maintaining lesser TAD, that is less than or equal to 25 mm. There were some studies trying to set the limit for TAD. This is one from IJOS. They have said that the limit for TAD is 25 mm. Up to 25 mm we have to maintain. Less than 25 mm they have to maintain. This is one more study from scientific reports that is published in PubMed Central. They have said the TAD value is 35 mm. So there were different studies trying to set the limit for a TAD. So most studies say set the limit as 25 mm. So we have to maintain TAD less than or equal to 25 mm is the certain thing, and we have to watch for post-op sliding.
So how to prevent anterior malreduction? You have noticed on
Sir.
you have introduced the you have reduced the fracture,
So
and you have studied that there is an anterior malreduction. How are you going to address that malreduction and put it back in the continuity of the path? What is the maneuver, or what are the maneuvers that are required to have anatomic reduction?
let better technique, nice.
You already reduced the fracture. There is only about 2 mm of malreduction.
Yes, sir.
Again, you will take back the, you will detach the
No, sir.
footrest and put the plate and then That is what is required now. You have noticed it. How to address that? He has not mentioned.
No, sir.
That is also important. How they have addressed it. Of course, this is a after their experience of presenting this paper,
Sir.
they must have altered their method of fixation or method of reduction, knowing that it is a problem.
Yes. They just mentioned that.
Purpose of the study is to reduce the fracture without any anterior small reduction.
They just mentioned that anterior reduction is in the surgeon's control. We have to prevent that. That is what they
How to
mentioned.
prevent? That is what
They
we want to know.
they mentioned.
Sir is asking if
Yes,
they
sir.
will put a derotation screw after getting a reduction, or they have used only a single helical blade or a single hip screw proximally.
Mm.
How will you have identified it on table? You
Yes,
are
sir.
doing your surgery.
Yes.
How will you get out of it? How will you bail out?
Ultimately, you have to give correction.
Yes, sir.
Problem, your solution చెప్పాలి. What is your
Traction is not going to
Yes, sir.
correct it.
So check for rotation.
Traction is not going
There
to
is
correct.
any
Rotation has to be checked
rotation.
in different direction.
Okay.
As internally rotating most of the time. Most of the time the fracture is externally rotating. To put it back into position, you need to put it in internal rotation. Sometimes it is not under your control.
Sir.
How to address it?
That means there is opening up of the fracture anteriorly.
Sir.
You must put a blunt pressure over the anterior aspect of the hip joint. If there is an angulation, most of the time,
Sometimes
You put a good padding,
Sir.
take a blunt osteotome on the other end of the osteotome, try to push it and check the reduction maneuver.
I will take
Then
if it is angulated,
Spike, sir.
put it on the anterior side and will try to press it down.
Or you can make a little opening, extend the incision where you are going to pass the guide wires, put a small Woman's
Spike.
retractor, which is pointed, blunt point, and then put it
Over the
inside
anterior
muscle,
femur.
and then put it underneath the vastus lateralis, and then try to
Pull
have
down.
control over the proximal fracture.
Yes.
That is how you can reduce it.
Okay.
If there is overlapping, you give a little more traction.
So after you reduce it, provisionally fix with the caver anteriorly, just below the anterior cortex or anterior neck, so that it will not displace again. Then you proceed with the repeat the procedure.
Until you put the guide wires, you have to hold the reduction. Somebody should apply the pressure.
Till the fixation over, you have to maintain the reduction. So what I have interpreted fracture, there is a sagging of the distal fragment. కిందకు వచ్చేసరికి పైన ఉంటుంది. So you don't have control over the proximal fragments. You have to
Each fracture is different.
yeah, each fracture is
You have to study the behavior of the fracture
yes.
on the table and do the maneuvers what is required, and that is a
That is very
on site judgment.
yes, on table judgment.
Each is different. Each fracture morphology is different.
Okay, sir.
You must use a bone lever.
Spike.
Sometimes these are osteoporotic fractures, so for getting a lesser TAD, you will try to go for more rotation. So sometimes you err more on in the inferior side, and you get one half turn back, so that you get the rotation right.
So always bone to bone contact and intraoperative the compression is the key.
Okay, sir.
If you attain bone to bone contact,
Whenever you are trying to put a drill over the guide wire, if it is not engaging especially in osteoporotic bones, if it is not having a good hold, when you are drilling, the proximal fragment is likely to get rotated and lose the reduction. So to prevent that, first
Yes, sir.
initially you put
K-wire.
the guide wire in the proximal part of the neck, close to the superior cortex, and then engage it into the joint so that it doesn't allow any rotation. This happens mostly with the BHS
basis
triple rumor. It is such a big reamer that it invariably it rotates.
Rotates.
These are all the maneuvers what are required for unstable fracture. It is an non-table judgment.
Yes.
Yes. Over.
Yes, sir. Thank you, sir.